everyone, I'm Dr. Muattar Hanif, Assistant Editor at Medical News Pakistan, and I'm so excited to welcome you all to this live session, GERD, Gastroesophageal Reflux Disease and its Management in Ramazan. I'm so thrilled to welcome our speaker, who is a renowned figure in Pakistan's medical fraternity, Professor Dr. Pervez Ashraf. He's Professor, Department of Gastroenterology, Liaqut National Hospital. Please, Dr. Pervez, join us in the video, and hello.
Thank you. Thank you. Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Well, I've chosen the topic of today is GERD, which is gastroesophageal reflux disease. This is a very common problem in gastroenterology circles, also with family practitioners and also with general physicians. And during the month of Ramazan, that they indulge in. This is a worldwide problem, and the incidence of this disease seems to be increasing, particularly in the Western world, perhaps because of the sedentary lifestyle and also because of the dietary indiscretions that most of us indulge in. Now, the American College of Gastroenterology defines GERD as a condition in which there are symptoms or mucosal damage which is produced by the abnormal reflux of gastric contents into the lower end of the esophagus. Now, everyone has reflux episodes, which usually are not problematic, and patients do not really complain of symptoms, or sometimes they just have to take 1 or 2 doses of an antacid, maybe once or twice a month. So this is not exactly GERD. When these, which patient 4 to 6 weeks and at least twice a week the patient should have symptoms, then we say that this patient has got gastroesophageal reflux disease. Now, this is a condition that is associated with considerable morbidity. If not diagnosed and managed adequately, most patients will have very frequent symptoms. They will also have nocturnal symptoms, which will lead to their loss of sleep, uncomfortable night, and also the quality of life will be severely hampered. And these patients then will also take time off work because they will not be able to sleep. They'll feel lack of energy during the day and they'll feel unwell. Now, I'll divide this talk into what the cause of gastroesophageal reflux disease is, then what the symptoms are, what are the complications of this disease, and then how do we diagnose it, and then finally, how do we treat it? So the main, talking first of all, the pathogenesis, why do we get gastroesophageal reflux disease? Well, gastroesophageal reflux disease occurs when, as I mentioned in the definition, we have reflux of the gastric contents. This is a smooth muscle which is present at the lower end of the esophagus, at the junction between the stomach and the esophagus, and this normally prevents reflux from happening. And how it does it is that this is smooth muscle, and this remains contracted. It has a pressure which is about 15 millimeter mercury higher than the pressure which is inside the stomach, or the intergastric pressure. And because of that pressure, the stomach contents are unable to reflux into the esophagus into a normal person. Now, additionally, there is the diaphragm through which the esophagus passes into the stomach, and the diaphragm has a very from happening and reflux barrier. Now, in people who have reflux, it has been seen that either they have a chronically incompetent lower esophageal sphincter, which means it is hypotensive. This pressure gradient of 15 millimeter is lost. The pressure is much lower, or sometimes the pressure between the stomach and the lower sphincter is almost the same. And that is why these patients will have reflux. And the second cause is that for some reason, these patients, they have transient lower esophageal sphincter relaxations, which occur not only during the meal, but even after they have eaten a meal. And that is why they will get these frequent episodes of reflux. Now, now becoming very prevalent in our society, and it is very common in the West, raises the intragastric pressure, and that is why obese patients are more likely to develop gastroesophageal reflux disease. Similarly, if you lie down, particularly after having a heavy meal, that also increases the intragastric pressure, and that is why after lying down immediately after a meal in patients with GERD, this will increase the reflux and they will become symptomatic. Now, gastric fractures also play a role in gastroesophageal reflux disease, and sometimes there's delayed gastric emptying or a condition that we call gastroparesis. Delayed gastric emptying can be physiological because of certain diseases which affect the muscles of the stomach, most classical of these being scleroderma. And then some neurological diseases also affect the nerves of the stomach, leading to delayed gastric emptying. And then gastroparesis, classically we see gastroparesis in diabetic patients, where they have a dilated stomach, the contractions of the stomach are absent, and that is why intragastric pressure is increased. The food that we eat remains in the stomach for much longer than normal, and that predisposes to reflux episodes. And then it is estimated that in about 15% of patients, the cause of gastroesophageal reflux disease lies in the stomach. There is either gastric paresis or delayed gastric emptying for some reason. Now, what are the symptoms? There are many symptoms of gastroesophageal reflux disease. The patient can complain of water brush. The patient can complain of a globus sensation, which means he feels that there's something sticking in the throat. The patient can have odynophagia. The patient can also have nausea. But the classical symptom that we get with patients with reflux disease, or which really allows us to make a clinical diagnosis without actually doing any investigations, is heartburn. And this is a burning sensation which the patient feels in the epigastrium, which radiates upwards into the retrosternal area, and this can radiate right up into the neck and sometimes spread out into the chest. And that is why a lot of patients with gastroesophageal reflux disease come to me after they think that they have a cardiac problem, and they go to see, first of all, a cardiologist, and they are investigated by a cardiologist, and then they are referred to a gastroenterologist. When they're told that they don't have a cardiac problem, the problem is probably a GI problem. So heartburn is really the classical symptom of gastroesophageal reflux disease. And if you have classic heartburn, then really a clinical diagnosis can be made and patients can be started on treatment. There are several atypical symptoms which you can get with reflux disease as well. These are mentioned in the books, but in clinical practice, they're not very common. But when patients do present with these atypical symptoms, then the diagnosis can become a bit tricky, or it can actually delay the diagnosis. Among these is hoarseness of the voice. The patient can develop pharyngitis and laryngitis, which will give them this globus sensation and will give them hoarseness of the voice. They can develop dental erosions. The acid, if it reflects right back into the mouth, it can lead to dental caries, dental erosion. The patient can, as I mentioned, have non-cardiac chest pain. And then importantly, the patient can have respiratory symptoms. Some patients in middle age can present for the first time with asthma. And there are now many studies that have now shown that middle-aged onset of asthma can be the initial presenting feature of gastroesophageal reflux disease. And this is mainly because of aspiration pneumonia. These patients, they aspirate small amounts of acid into the trachea when they lie down after taking a heavy meal. And many studies have shown that treating these patients with proton pump inhibitors can actually relieve the symptoms of asthma. So in a middle-aged patient presenting for the first time with respiratory symptoms, particularly with asthma, with bronchospasm, these patients can be given a trial of proton pump inhibitors to see whether that improves their symptoms or not. Now, one thing to remember is that many of these patients with these extra esophageal symptoms, as we call them, or the atypical symptoms, may also present with heartburn. Now, when they present with heartburn, then it is easy to link these symptoms with the reflux disease. But sometimes these patients will have only the occasional heartburn, or they may not complain of heartburn at all. And that is when making a diagnosis of reflux disease in these patients is not that straightforward. Now, how do we diagnose gastroesophageal reflux disease? Now, most societies around the world, they say that gastroesophageal reflux disease can be diagnosed on the basis of taking a good clinical history. And this clinical history means that the patient has been having the classic symptom of heartburn, which is retrosternal burning. And this sometimes increases after taking a meal. And importantly, these patients, they can link these symptoms of classical symptoms of heartburn with certain food items that they take. And these are in the West, alcohol, smoking, if you take a lot of cheese, if you take a lot of tomato ketchup or sauce. So these food items, they can increase your symptoms of reflux. So these societies, what they suggest is that the patient gives a clinical history of heartburn or nocturnal symptoms of heartburn for 4 to 6 weeks. Then you can give them a trial of a proton pump inhibitor for 2 to 4 weeks. And if these patients respond to the proton pump inhibitor, then that in itself is confirms the diagnosis of gastroesophageal reflux disease. And these patients, they can be kept on a proton pump inhibitor and managed as patients of gastroesophageal reflux disease. Now, we need to investigate patients when patients either have atypical symptoms or we have put them on PPI. We have given them this clinical trial of 2 to 4 weeks of PPI, and the patients have not responded to treatment. So now we are in trouble, and now we need to know what is the cause of the heartburn. So in the diagnosis, you can perform X-ray studies. First of all, I mentioned X-ray studies, first of all, because as a gastroenterologist, we do not like to perform barium swallow studies in patients who present with heartburn. Mainly for the reason that this is insensitive. The barium study cannot tell you what the mucosa looks like. And in most patients with GERD, when they have heartburn, they will have inflamed esophageal mucosa. They will have superficial ulceration of the esophageal mucosa, which the barium study will not be able to pick up. And that is why we do not like to get the barium studies done. If the patient presents with dysphagia, then barium studies are quite helpful. In fact, before going into an endoscope, we may like to have a look where the obstruction is and what sort of obstruction is. And there, the barium studies are certainly complementary. After the barium studies confirms that there is an obstructive lesion causing the dysphagia, we still have to go in with an endoscope and perform an upper GI endoscopy. So that is why most gastroenterologists like to perform the endoscopy as the first investigation when we decide to investigate. Now, without putting the patient on a clinical trial, we'll first of all do an endoscopy if a patient presents to us with alarm symptoms. Now, these alarm symptoms are the patient says that I've been having heartburn for several days or weeks, and I was taking some medication, but I didn't respond completely. And the patient presents to us with anemia, which means a low hemoglobin. So then we need to know, why is the patient losing blood? Is there ulceration, or is there something more serious? If the patient says that the patient has had an episode of hematemesis, or the patient has had melena, then obviously we would like to investigate what the cause of the hematemesis or melena is before we actually start this patient on treatment. If the patient gives a history of weight loss along with, even if there's classic heartburn, we would like to do an endoscopy or some sort of investigation before we put the patient on treatment. And importantly, in a middle-aged patient presenting for the first time with heartburn, and if there's a strong history of GI malignancies, then the right thing to do is to endoscope this patient before starting this patient on treatment. Now, the other advantage that endoscopy gives us is that there are two things we do on endoscopy. First, we have a look at the mucosa. And invariably, if the patient is complaining of heartburn, there will be inflammation of the esophageal mucosa right at the lower end of the esophagus. And sometimes in severe cases, this can extend right up to the mid-esophagus. So that is one thing we do. Secondly, we look to see whether there's any ulceration or not. And there's a Los Angeles classification which grades it as A, B, C, and D according to the grades of inflammation that we find on endoscopy. And then lastly, a very important thing or a complication of long-standing GERD is Barrett's esophagus. And this is something which has to be taken seriously. Now, the one point that I would like to make here is that I have been practicing gastroenterology in Pakistan for the last 30 years, and I find Barrett's esophagus not to be very common in our population. Although when I was practicing in the West, and when I read the literature from there, they put a lot of importance on Barrett's esophagus, and they have a lot of patients with Barrett's esophagus and patients who have reflux disease. But fortunately, we do not see Barrett's esophagus that commonly. Now, Barrett's esophagus was first described by a cardiothoracic surgeon in London, and his name was Norman Barrett, and that is why this is called Barrett's esophagus. And Barrett's esophagus is when the lower end of the esophagus, which is normally lined by a squamous epithelium, is replaced by a columnar epithelium, which has a pink color. You can easily identify this difference when you do an endoscopy because the color of the mucosa changes, but this mucosa is within the esophagus. This is columnar mucosa, but this is abnormal column. This is not normal columnar mucosa. This is intestinal metaplasia. So that is why this is abnormal, and patients with Barrett's mucosa need to be biopsied. To confirm the diagnosis, you have to take a biopsy, and this has to be taken 4-quadrant biopsies at 2 centimeter intervals, and these have to be then interpreted by a histopathologist who has expertise in interpreting esophageal biopsies. Because as you all know that Barrett's mucosa is a pre-malignant condition, and adenocarcinoma of the esophagus, which is one of the complications of long-standing gastroesophageal reflux disease, usually develops in a pre-existing Barrett's esophagus. So that is why patients with Barrett's mucosa need to be kept under observation. There are screening protocols for these patients where they need to be screened at regular intervals to have a look at this mucosa, and there are different treatments that can be given to get rid of this Barrett's mucosa. The complications of Barrett's are, as I said, ulceration. And one practice point that I would like to give you, one symptom in gastroenterology we call odynophagia, which is pain on swallowing. Now, this is a classical symptom you get when a patient develops an ulceration in the esophagus. And if you ask a patient to point where the burning sensation is, the patient will quite accurately point to the level where the ulcer is, right? Where the ulcer is, the patient will put his finger and tell you that this is where the pain is when the patient swallows. And this is called odynophagia. And this patients with GERD, when they develop ulceration, they will put their finger and tell you where the pain is, and when you endoscope, that is where you will actually find the ulcer. And another condition in gastroenterology is pill esophagitis, when some people, they swallow a pill without taking water, the spill gets stuck in the mid-esophagus, and they develop an ulcer there, and they also have severe pain and odynophagia. And if you ask them, they'll put a finger right in the center of their chest on the endoscope. That is where the ulcer is. So odynophagia is actually a symptom where the patient can localize where the pain is, and that is where the ulcer is. Okay, now the third investigation which we do in these patients is the pH manometry test. Now, this is not widely available in Pakistan. There are only a few centers that do these studies, and also there, it's not very easy to get these studies done. And this really, the place of pH manometry studies are in those patients who fail to respond to treatment, which is when you give them a PPI, they still come back to you and they say that they haven't had relief of symptoms. So firstly, you want to know, is this really GERD or is this something else? So that is when you do a pH manometry study, and in this you place a manometer, a pH probe, which is placed transnasally, and it is placed 5 centimeters above the lower esophageal sphincter, and then there's a recording of the pH which the patient carries with him. Patient remains mobile throughout the 24 hours, and that probe monitors the pH, and it is positive. The recording is positive, or acid reflux is considered to be present when the pH is recorded at below 4. And the patient is asked to keep a diary. And whenever the patient feels heartburn, he writes down in the diary what the time is. And at that time, we check after the recording is complete, the number of episodes of heartburn that the patient has written down in the diary. We compare that with the recording, and we match as to whether the pH was below 4 at the time that the patient was complaining of heartburn. And if at the time of the heartburn episode, the pH monitor records a pH of less than 4, then this is acid reflux, and the patient is having symptoms because of acid reflux. So then we need to treat this patient more aggressively with the proton pump inhibitors. And if when the patient develops these heartburn episodes, the pH recording is above 4, then these are not episodes because of acid reflux. So this patient then either has a hypersensitive esophagus, or there's some other cause for the heartburn. Right. Barrett's esophagus is also divided into long segment and short segment Barrett's. The longer you have, if you have it more than 3 centimeters in length, it's called long segment Barrett's esophagus, and the risk of developing adenocarcinoma is greater in those patients who have longer segment Barrett's. Now, another form of pH monitoring is the capsule pH monitoring, Bravo capsule, in which endoscopically you place a capsule, and this also in the lower end of the esophagus, and this records for 48 hours. But in this, you don't have the transnasal probe, so this is not that uncomfortable. But some patients complain that they have sensation of dysphagia, or they can feel the capsule, and this capsule is then spontaneously passed out, and again the recording is checked. So these are the different diagnostic modalities. Now we come to the treatment. Now there's a treatment which is medical, there's a treatment which is surgical, and there's an endoscopic treatment as well. Now, first of all, I'll talk about the medical treatment, because I'm a gastroenterologist, and in my practicing lifetime, which is about, I've been practicing gastroenterology for the last 30 to 35 years. There's only one patient I remember whom I had to refer to surgery for gastroesophageal reflux disease because of uncontrollable symptoms. But I have a suspicion that that patient was very non-compliant of his medication, and that is the reason why I then suggested to the patient that I think you better go and have surgery. So proton pump inhibitors, which are the mainstay of treatment of gastroesophageal reflux disease, are very powerful acid inhibiting drugs. The parietal cell in the stomach, which produces the gastric acid, has got 3 receptors on it. There's a gastrin receptor, there's an H2 receptor, and there is a acetylcholine receptor. So, but all of these three receptors, when they are stimulated, they produce the fluid, and the final step in the synthesis of acid is the ATPase, which is the proton pump. And the proton pump inhibitors, they block this pump, this ATPase pump, and so they block the production of acid in its final step. And that is why they are the most powerful acid inhibitory drugs currently available. And if you give them in high enough dose, you can produce almost a state of achlorhydria in the stomach. So that is why since the advent of proton pump inhibitors, life for gastroesophageal reflux disease patients has become much easier, and they have had now comfortable nights. They can sleep comfortably at night by taking adequate doses of the proton pump inhibitors. By and large, proton pump inhibitors are extremely safe drugs. They have been in the market for almost 35 years now, and they have an excellent safety record. In the last decade or so, there are a lot of anecdotal reports about side effects that have been seen with proton pump inhibitors. These include pulmonary infections, these include GI infections, these include bone disorders, interstitial nephritis, and cardiologists also reported side effects with omeprazole when patients were taking clopidogrel along with the omeprazole. But on the whole, these drugs are very safe, and the guidelines still suggest that you should only prescribe these drugs with caution in these patients where they have the bone disease or they have renal disease. They do not recommend not giving these drugs. So these drugs still are the first-line treatment in all patients with gastroesophageal reflux disease. Now, apart from drug treatment, another very important of medical treatment is lifestyle modification. And lifestyle modification in many patients will be very helpful. Some patients may be able to reduce the dose of the drug. Some may be able to go off drugs, or if they're taking it daily, they may be able to take them maybe on alternate days or twice a week if they resort to these lifestyle modification. Now, of these is weight reduction, which is very important because weight increases the intra-abdominal pressure and that predisposes to reflux. Stopping of smoking. Smoking relaxes the lower esophageal sphincter, so that will predispose to reflux episodes. Alcohol, again, predisposes to reflux. We know that by taking a heavy meal, you raise the intragastric pressure. So we advise patients to take small meals and frequent meals rather than taking too large meals in a day. And most importantly, you must ask the patient, particularly those patients who have nocturnal symptoms, they get heartburn at night during their sleep, they have to get up and take antacids. We advise these patients to take a meal at least 3 to 4 hours before going to bed. And this is very, very helpful. Another helpful measure is if you elevate the head end of the bed about 4 to 6 inches. This is a bit uncomfortable for the patient, but most patients who do elevate their head end of the bed, they find this quite useful. And after a few weeks or months, they get used to it. So then they stop complaining about it. So medical treatment along with lifestyle modification, in my experience in gastroenterology, these are sufficient to allow a patient to live a normal life without actually having to go to surgery. Now, another thing which you must ask in taking the history of these patients, we know that several drugs can delay gastric emptying. They can relax the smooth muscle. The most important of these are the calcium. A lot of patients, particularly salt, I've seen a lot of my patients taking amlodipine. They are hypertensive, and this has been prescribed by the cardiologist. The tricyclic antidepressants, just patients who have reflux, and if they are taking beta adrenergic inhalers, they can also predispose to reflux episodes. Theophylline tablets in the oral form, which a lot of patients might take, they also predispose to reflux, and they have an effect on the lower esophageal sphincter. Now, there are other drugs which are used as adjunctive therapy, which means they're not the first line treatment, but in patients who are taking, say, one tablet of a proton pump inhibitor a day, and they still have symptoms off and on, you can add an adjunctive therapy. And the most common of these is the prokinetic drugs, which increase gastric motility, and thereby they increase gastric emptying, and they can be quite helpful if they're given along with a proton pump inhibitor. H2 blockers, as you know, one very common H2 blocker, ranitidine, was recently removed from the market because of the side effects that have very recently been recognized with this drug. But H2 blockers were also given to some patients who had mild GERD, or patients who had GERD. They were well controlled on PPIs and they wanted to step down. So then we switched these patients onto an H2 blocker, and sometimes we could manage them quite well just on H2 blockers. Another adjunctive treatment is antacids. Patients who are not well controlled on PPIs, or and have often episodes of antacid of heartburn, they can get relief by taking antacids. So these are adjunctive therapies. These are not used first line. They're usually given in conjunction with the proton pump inhibitors. Now, I'll mention surgical treatment. As I said, in my experience of 35 years, there's only one patient whom I've referred for surgery. But surgical treatment for gastroesophageal reflux disease have made advances, very good advances, and the fundoplication technique, which is performed laparoscopically, is now very successful for patients with GERD. And though I do not refer patients routinely for surgery, but if you have a young patient, say, who's in his late 20s or early 30s or early 40s, and you tell this patient that GERD is a lifelong condition, they'll be on treatment for lifelong, then many patients will then opt to have surgery if they know that this is a definitive treatment and they go off medication. They will opt and say that I would like to have surgery. So the fundoplication technique now is a very good technique, and this is performed laparoscopically, and patient is usually out of hospital the very next day. But as a physician, the one thing that I would caution is that all surgeries have their complications. Some patients after surgery, they start complaining of dysphagia. Some say that they've got what we call the gas bloat syndrome. They have gas in the stomach, which normal people, they will have hiccups and they will be able to get rid of that gas. They belch and get rid of that gas. These patients, they can't belch adequately. So they complain of this gas bloat syndrome. Then remember, there is a very small risk of mortality, 0.5 to 1% mortality, which medical treatment does not have. So patients should be told that in very experienced hands, this mortality is very low, but people who don't do very high volume laparoscopic procedures, the literature mentions the mortality can be between 1 to 2%, which then becomes quite significant. So this should be discussed with the patient when they're being referred for a surgery. And then now the literature says that after patients who are completely asymptomatic, about 40 to 50% of them, they go back onto medication. They start developing recurrent heartburn, and they need to off and on take medication, or at least antacids. So this is also something which needs to be discussed with the patient. And then finally, I'll talk about the endoscopic treatment. There are endoscopic techniques by which you can reduce the reflux episodes, and these include injecting certain substances into the lower end of the into the lower esophageal sphincter. What this does is that this hardens the lower esophageal sphincter, so it prevents reflux. And but these have only temporary effect. there are endoscopic stitching techniques now that are available, which have been tried by some people, and some studies now have shown that these endoscopic stitching techniques are effective and they can relieve the symptoms of reflux. But by and large, none of the societies today recommend these as first-line treatment, and they are not in the guidelines as yet. So these are still developing. Maybe in the future, endoscopic techniques or treatments for gastroesophageal reflux disease may become more popular. Thank you very much.
Thank you, Dr. Pervez, for taking time out of your busy schedule and guiding us through your knowledge. I hope the listeners have also enjoyed the session as well. Thank you once again, sir.
Okay, thank you. Thank you very much.